All right, welcome back to another episode of The Monk and the Hedonist. Deepthi, how are you today?
I'm doing well, Bobby. How are
I'm doing
you?
pretty good. What are you drinking today?
So, I actually have a treat. I thought I needed a treat for this episode, and I made myself a Nutella latte. So, I think I might be on the hedonist side today.
Nutella. Oh, I love Nutella. Yeah, I'll have to try that sometime. I'm really boring today. I'm actually uh, in my office in my clinic, so I'm just drinking some coffee, Nespresso coffee. So I'm really excited about today's episode, though. We are going to be talking about men's sexual health, and it's such a relevant topic. And we have two guests on our show who are experts in men's sexual health. So I would like to introduce them. First of all, Dr. Vipul Khanpara is on the show. Hello, Vipul.
Hey, how's it going, Bobby?
Good, good. And we also have Ken Bains. Um, so just a little bit about both of our guests. Vipul is actually an ER doc. He's been an ER doc for over 15 years, and he's also the chief medical officer of a company called Rugiet, which we will be talking a little bit more about. And Ken is actually the chief of pharmacy for Rugiet, and he's been um, a a compounding pharmacist, and he's championed over 13 pharmacy startups over the past 20 years. So again, welcome on our show. Um,
Thank you for having
yeah.
us.
So Vipul, what are you drinking?
So I'm not quite as exciting, but I have a Ipanema Peach Bai. So I don't know. These have been my go-to. My wife's been stacking the fridge full of these, so I just pulled one out, and they're actually pretty refreshing. So that's my go-to today.
I drink those quite often as well. What about you, Ken?
Well, I live in sunny Miami, Florida, so I've got icy cold water.
Sunny Miami. I'm jealous. It's 5 degrees over here in Iowa currently. How is it over there?
Oh, it's beautiful. Beautiful day. Always sunny, palm trees.
Yeah.
I live on the beach, so it's beautiful.
Very very nice.
Everyone's the monk today except
Yeah.
me.
Right.
Well, let's get into it then. You know, as I mentioned, we're going to be talking about men's sexual health, and there's a lot to talk about. You know, for anyone who is familiar with some of the statistics for you know, men's sexual health and sexual dysfunction, it's actually quite alarming. And you know, first, I think when we define sexual dysfunction, I think there's several different components. You know, there's erectile dysfunction, there's ejaculation disorders, or just disorders on achieving any type of pleasure when you're having sex, or even just the loss of sexual interest, right? So today's show, we're primarily going to be focusing on erectile dysfunction because that's probably the most common. Would you agree with that, Vipul?
Yeah, certainly. I feel that's the most common and also the most well recognized of all the, sexual dysfunctions.
So how common is you know, erectile dysfunction as a problem for men, and when do we really start seeing that becoming an issue?
Yeah, no, that's a great question. It's a tough answer to that. The best data we have come from different kind of questionnaire-based data collection studies that have been published, and there was actually one done in the late 80s that people still cite, and that was the Massachusetts male aging study, where they collected data from just a bunch of men between the ages of 40 and 70 in the Boston area. And from that data, they reported that the prevalence was 52% in that age group. So, men aged 40 to 70, there was a 52% prevalence of any form of ED. And then other numbers that have been cited, I've seen most recently that it's estimated that there's about 30 million men in the USA that they feel are currently afflicted with erectile dysfunction, which are both actually quite eye-opening statistics, in my opinion at least, to know that over half of you're more than 50% likely to develop ED at some point in your life, and yet it's still so stigmatized. And the good part there is that I think there's a lot of room for change and to destigmatize, but certainly some eye-opening numbers there.
Yeah, with with erectile dysfunction, that there's probably just a compounding problem, not only when it comes to sexual performance, but even on an emotional level. There's probably some really profound impacts to that, and even there's probably some issues that can arise even with relationships and how you relate to your partner if that were to happen. So if someone is a 20-year-old, a 30-year-old, a 40-year-old, they may be thinking, well, I don't have this issue, compared to someone who's 60, 70, or 80. When do we really start seeing this kind of becoming more common? Which age groups do we really start seeing it happen?
Yeah, it's always been thought to be a disease of older men, it used to be thought men over 50. Well, then we started looking at a significant amount of men in their 40s were suffering from ED. And I feel that as time has gone on, that number keeps getting lower and lower. So there's really no clear-cut answer there. Certainly, 40s and up is when we really start seeing the prevalence increase. The prevalence actually jumps about threefold after you reach the age of 40. But we are still seeing, a significant amount of our patients and patients in general in their 30s and some even in their 20s. And I think a lot of this is due to the increase in prevalence of the contributing conditions to ED, increasing in prevalence, in these younger populations these days.
What are some of those issues? Because historically we've thought, they're related to some sort of vascular issue or diabetic, but a lot of it's lifestyle now these days. So what kinds of things are you seeing, especially in younger men?
Sure. So, no, you touched on two really important ones, which are hypertension and diabetes. And even those two are becoming a lot more prevalent, as you guys know, in the younger populations these days. So certainly diabetes, high blood pressure, chronic renal disease. But some of the ones that I think are more specific to the younger populations, in my opinion, are one, drug and alcohol use and abuse can certainly contribute to ED. The other thing that's become much more prevalent, I feel, as of in the last couple of decades at least, is the use of different medications to treat in the treatment of certain mental health disorders and other things, hormone treatments. These things are becoming a lot more common, and these things are also contributing factors to erectile dysfunction. So on top of those, there's also smoking, certainly obesity and sedentary lifestyles, which has been kind of the trend, unfortunately, are all reasons that we're seeing a younger and younger age now of onset for erectile dysfunction.
When you mentioned drug use, what about cannabis specifically? Because obviously, as that becomes more and more legalized and broadly accepted, what does that play as far as what role does that play in erectile dysfunction?
Yeah, sure. So cannabis has been linked to erectile dysfunction. I think it's kind of a multifactorial effect it has. It's different from just smoking tobacco, which we know causes damage to blood vessels over time. Cannabis kind of works in a different ways, but certainly has been linked to erectile dysfunction. And as you mentioned, with that's becoming more common and legalized in states across the country, I could certainly see that adding to the prevalence of ED. And there's other illicit drugs as well. Cocaine, all the cocaine, methamphetamine, all the stimulant uses also have similar effects of damage to blood vessel over time. And so certainly the illicit drugs can all, in one way or another, affect your erectile function.
What about even just a sedentary lifestyle? There's this phenomenon that's popping up with software engineers and people who tend to spend a lot of time at their desk and in front of a computer. What are you seeing there? What kind of trends?
Yeah, so the sedentary lifestyle again is linked with a lot of these other comorbid conditions, right? So you are less active. Guys tend to gain weight. They tend to be more likely to get type 2 diabetes, have high blood pressure. So again, there's a link between all of these different things. But more so than that, sedentary lifestyle and a lack of exercise has been shown to also be a contributing factor to low testosterone levels. And we all know that as you get older, your testosterone levels tend to drop. Well, we're seeing it at younger and younger ages now. Partly due to exactly what you mentioned there with this kind of, move to the workforce of being more sedentary. You mentioned software engineers, but it goes well beyond just that industry. And I think that certainly we know that testosterone levels and low testosterone levels are linked to erectile function as well as other health conditions. And so I certainly see that being one of the links there.
You bring up a good point because, when I think of erectile dysfunction, I think of it more so as a blood flow or a circulation issue. How does testosterone play a part in erectile dysfunction?
Yeah, so I actually kind of think of it in a couple ways. I think of erectile function from a blood flow standpoint. And when I think of that, I think of it more peripherally as to, how things are working down in the penis. And so essentially there is the dilation of blood vessels and the engorgement of the penis and all the chemical mediators involved in that process. But I also think about it from more of a central pathway as there is a need for, arousal, stimulation. There is a kind of more of a nerve component to erectile function as well. And it's actually both of these pathways that can, issues with either of these pathways, I should say, can contribute to erectile dysfunction. And so when we look at how testosterone fits in, it actually kind of fits in both pathways because, guys with lower testosterone, it's been shown that these gentlemen have lower, libido or sex drive, which is needed in order for, appropriate erectile function. And then there's also effect on, with testosterone and other hormones as well on the vascular flow aspect of what's needed for erectile function. So I think it actually touches on both those pathways.
Yeah, I treat a lot. I treat a lot of prostate cancer, so this topic is very relevant in my own clinical practice. But when I deliver radiation to someone's prostate when they have cancer, the prostate is surrounded by a neurovascular bundle. So the radiation is damaging those nerves, and on top of that, oftentimes if you have prostate cancer, we also give patients a testosterone hormone blocker. So not only are we, potentially damaging some of those nerves that innervate for an erection, but we also are temporarily shutting off their testosterone. They're kind of going into a male menopause. So both of those, so erectile dysfunction is a big issue with prostate cancer patients when they're getting their treatment. Certainly it makes sense as to why testosterone has a big part.
Yeah, and Bobby, just to add to that, beyond just the radiation, a lot of these men ultimately undergo some form of prostatectomy or prostate removal. And during those procedures, as you know, there's often, there's the possibility of damage to some of those nerves that are involved in that pathway. And so oftentimes there can be a transient or even sometimes a permanent damage to some of those nerves involved in that pathway. So we do see a fair number of our patients that are, post prostatectomy patients that are having issues with erectile function.
Yeah. So as we, before we get into, how we treat this, when a patient comes to you and tells you that they're having a difficult time getting an erection, how do you work that up? Like, what kind of testing do you do, and how do you get to kind of the root cause of that?
Yeah, so we don't do any testing per se, but what we have done is, through our platform, we've essentially created a comprehensive medical questionnaire that really touches on all the different pieces that any doctor, were you to see them in person or through telemedicine, would want to know as part of diagnosing and treating erectile dysfunction. So, we start by wanting to confirm the diagnosis. So we certainly ask questions about your sex life and experiences and issues with erections and so forth. We ask questions about if you have sexual performance anxiety, because we know there's a component that is that can be from mental health and anxiety. And then we look at, based off of those questions, if they meet certain criteria for treatment, and then we want to also make sure the treatment's safe. So we look at coexisting medical conditions, medications they're taking that may preclude the use of some of our treatment options. So we certainly want to make sure we're capturing all that information so our doctors can make the best and safest decision possible for our patients in determining their treatment. And we try to be, even redundant in certain areas, just to be extremely safe with particularly the big contraindications to some of the medication treatment options that we offer.
Yeah, it makes sense. I think that, since there's so many different potential causes for this, it makes sense that you need to probably get a global picture before prescribing a particular treatment. So as we dive into treatments, then, what are some of the best natural things that just men can do to prevent erectile dysfunction, or if they have it, to treat it naturally? Sure.
Yeah. So I think some of the things we've already kind of touched on, but I think just a healthy lifestyle. I think that would be the easiest way to put it in a sentence. But and in my eyes, at least, that includes healthy eating. So it starts with your diet. Making sure that you're eating the right foods. And there's different information out there, but in general, I would say just unrefined foods that are low in preservatives, whole foods. There is some thought that eating foods high in zinc, high in L-arginine, these are some of the precursors to testosterone and nitric oxide, respectively, and so some of those foods might have some benefit with erectile function. But in general, healthy eating, I think, is first and foremost, and then there's certainly exercise. Exercise has been shown over and over again to improve cardiovascular health, help delay or prevent vascular disease, and hence, allow for better erectile function for, a longer period of time. And beyond, those two, there's the things, lifestyle modifications, things you can cut out. Can you do without? Are you drinking too much? Alcohol consumption and increased alcohol intake has certainly been shown to be a contributing factor to erectile dysfunction. Smoking, can you cut out smoking and quit it altogether? Cut out illicit drugs, and then have a good, healthy conversation with your doctor about the symptoms you're experiencing. I mean, it all starts with the patient. If the patient's not willing to recognize these symptoms and have the discussion with their physician, then ultimately, they're not going to get the help they need. So it's really up to the patient to be forthright with their doctors and take the initiative, and then have that discussion, and then there's going to be, there might be, for example, some medications that might be contributing that the patient may not be aware of, that their primary doctor may be able to, help them adjust or put a new medication in its place and see if that helps. So those would be the types of things that I would certainly urge most patients, all patients, regardless of whether or not you will still require other medical treatment, to make it a point to do.
Yeah, and just to add, Vipul, so we're not giving medical advice on this podcast without people consulting a doctor. So with the zinc and the L-arginine, people need to consult someone before they just start taking them, because there's other reasons why they may or may not want to be on it.
Absolutely.
The other thing I wanted to add too is when we talk about low testosterone, sleep is an extremely underrated component to our hormonal levels, and especially testosterone. So that is something that people can see exponentially increase with just increasing their baseline sleep levels. So that's another thing to add in the armamentarium of natural remedies.
Very good point. Yeah, I think sleep has a huge effect on your overall health, and that's a good point. That regular sleep cycles and making sure you get plenty of good sleep is extremely important.
Yeah, to summarize some of your points then, if we were going to create like an all-star list of things you can take or do to reduce the risk of erectile dysfunction, sleep at least, would you say 7 to 8 hours is kind of the stats I've been reading. Anything below that, your risk of erectile dysfunction starts going up. Avoid certain habits like smoking and other drug use, like alcohol. Exercise. What other supplements can people take to help? I've some of the research I've seen is ashwagandha can be good to increase your testosterone naturally. Anything else that you've come across, Vipul?
Yeah, I'll put it this way: there are plenty of supplements on the market out there that I know have at least maybe demonstrated some evidence behind, but there's also certainly a lot that might not have such strong evidence behind. So I try to stay away from recommending one supplement over another, just because there's so many out there, and the data's, in my opinion, not very strong for many of them. And so, yeah, you're right. I've heard of ashwagandha. There's this Nugenics. You've probably seen commercials for that. And there's different, extracts and herbal options and things like that. But I think in general, I think it's just the healthy eating, making sure you're getting, I would say a daily multivitamin is probably not a bad idea. And besides that, it's really just the healthy eating, the sleep, and exercise.
What about testosterone? Because I know that there are several prescribers who prescribe testosterone via injection into their patients. Do you have an opinion on that? Is there certain levels of testosterone that we should look at, and if it falls below that, when do you start supplementing testosterone?
Sure. So yeah, in general, there is a range of a normal testosterone level, and it ranges somewhere in the order of 240 to, the low 900s of what's considered typically normal. And most physicians who practice in that space will probably start looking at, formulating a replacement plan when you're in the numbers of 300s or so or below. Again, depending on your symptoms, depending on your age group, things like that. So there's a lot of factors that are considered when determining if you're a candidate for testosterone replacement therapy. And certainly, our physicians will actually have that discussion with patients as part of their recommendations, and certainly if the patients bring that point up, they'll further that discussion. But we got to keep in mind that it's not. I'd like to stay away from the thought that just increasing testosterone levels is the cure here, because it may not even be the cause of your underlying erectile dysfunction. And furthermore, there certainly are conditions that would be risky to start somebody on a testosterone replacement therapy, as well as some of the risks involved need to be very clearly explained to the patient. So I would say in general, if you're symptomatic, you get your testosterone levels checked, you're in that range of low, what's considered low T, it certainly is worth having that discussion with your doctor as to the risks and looking at more of a general view of your health and your medical conditions to make that decision. But I certainly wouldn't say that it's necessarily the treatment for everybody.
Let's say you get it. Let's say your erectile dysfunction is caused due to cardiovascular disease or something like diabetes, where you have some kind of impairment into the vascular system, right? Do you know of patients that were able to reverse that naturally, or once you have it, and then you need to start getting pharmaceutical intervention?
I see what you're saying. No, and I don't think that's the case. I think I'm a firm believer that making these lifestyle adjustments, getting your underlying conditions under control, does have a positive impact and even a reversible, impact. And we've actually seen patients that have gone from needing perhaps higher doses of PDE5s, which are the medications like Viagra and Cialis, to requiring either lower doses or coming off of the medication altogether when they've made certain lifestyle modifications. They cut, they stopped smoking and they stopped drinking as much, or they've lost weight and they've been exercising. So I certainly feel that there is, ways to reverse that. And to your question directly, we know in other aspects of vascular disease that these measures do improve vascular health, and so I have no reason to believe that it wouldn't do so in the vascular health, in the penis and in the erection pathway.
Great. I would like to kind of dive into some of the pharmaceutical management now, and first out of disclosure, especially for me, as I've mentioned to you, I treat a lot of patients with erectile dysfunction due to prostate cancer. So I was really, intrigued when I first heard about rugiet and what it's doing. So, in disclosure, I am an investor in rugiet, and so is Deeply. So if we can, Ken, let's start with you. If we can start, talking a little bit about some of the most common pharmaceutical ways to manage erectile dysfunction, and if you can even talk about maybe some of the mechanisms involved, and that would be great.
Yeah, so from a pharmacist perspective, I know as a physician there's a diagnosis perspective, but kind of give my background, it's a little bit of a locker room talk with the patient too, because initially when a patient really finds out, whether it's their spouse or their significant other, that it didn't get hard enough or it didn't get hard, performance anxiety the second time is going to be there no matter what. So whatever pharmaceutical dosage form that you give them, and even if they're pre-diabetic, or their A1C's here, or they need some lifestyle modifications, they've already added this performance anxiety regardless of whatever pharmaceutical dosage form that you give them, because in their mind the last time it didn't work, they don't know if it's going to work this time. So there's a real big conversation piece of how open that patient's willing to be with you, and trying to kind of dive in and say, okay, are you, everything that we've touched on before is sedentary lifestyle? Are they overweight? What could be the contributing factors that's leading them into this erectile dysfunction? But I think one of the most important things is really getting that diagnosis right, and then slowly titrating that dose, low and slow, and trying to also give that counseling there that their partner is going to have to be understanding. That we're not going to probably get it right on the first try, but we're going to work you through and slowly titrate you there and get you better, right? But it's not just one, as we just touched on so far. It's several different factors that's really going to get them that optimal performance, and that pharmaceutical is just going to be an adjunctive treatment Unfortunately, what we've seen in the U.S., we always want a quick fix. Is everyone just jumps straight to the pharmaceutical and thinks that's what's going to fix it, right? But really, it's usually just a bandage. And what ends up happening is that bandage is going to end up coming off, and the underlying disease state, or the many different disease states, or the lifestyle modifications and the diet and the food and everything else, it just gets worse and worse and worse. And that's why we've seen this huge population of trimix, which I'm still shocked at, that we have such a huge patient population now. That's, like you said, a lot of vasculature damage that's led them to trimix as an option, and the only option.
What is the most common drug of choice for erectile dysfunction?
I don't know the stats on that, but I'd say probably Viagra, just from a marketing perspective, probably around the world. And then secondary would be the tadalafil cialis.
And can you explain the differences between those two, the Viagra and cialis?
Yeah, sildenafil overall, just the chemical, is a very old chemical in the sense that it's always been used for pulmonary arterial hypertension, so for PAH. So we've, as compounding pharmacists, we've always had this medication in the raw ingredient API used for PAH. So we'll make CAD cassettes and infuse patients 24/7. But then obviously when the clinical indication came that it works so well for erectile dysfunction, it has a shorter half-life, in the sense about 8 hours, while cialis, the longest is between 17 to 36 hour half-life. From my talks with patients, I don't know if there's a lot of clinical, Vipul would probably know more of the studies, but I've seen more patients who really need a stronger and harder erection on just the Viagra. And then the patients that necessarily more of the cuddle, they always say the cuddle tablet, which is probably more of the cialis. And then again, I always tell people it's just like Zyrtec and Claritin. I think there's some receptor affinity difference also from patient to patient, where some patients will be like, I get terrible side effects, or Viagra absolutely doesn't work for me, and a 10 milligram tablet of cialis will work perfect for them, and that's just their choice. So I think there's some receptor affinity between patient to patient.
So Ken, you talked a little bit about the drugs on the market, and you're the pharmacy mastermind behind coming up with Rugiet. So what sort of went into your thought process with a new pill for the same purpose?
Yeah, so when it comes down to compounding, for those of our listeners that don't know much about compounding, the thought process always comes by is how can we use an approved active pharmaceutical ingredient? So this is already approved in a tablet form or any other form that's already existing, and using great docs like Vipul, who also are thinking about what are some of the side effects of these drugs, what are maybe some of the adverse events. How can we use this drug in an alternative dosage form at a specific site to kind of decrease either those side effects or get a better optimum therapeutic effect, right? And maybe even sometimes combining it with some other medications, because they've already had so many treatment failures by using commercially available dosage forms. So that's where they kind of go back and say, okay, from a safety efficacy perspective, let's see if this works. We've tried all the other commercially available dosage forms. It's not working for them. I think if we combine A, B, C, D, API, Ken, do we have a formulation for this? And we usually present that to the doc. They take a look at it and say, yeah, let's try it. Let's start low and slow and titrate them up. So especially with this erectile dysfunction, and we know that there's so many factors that affecting patients, the majority of these patients who want a compounded dosage form, they've tried the tablet form. This is not their first time that they've suddenly experienced erectile dysfunction, and they're saying, hey, can I get a sublingual dosage form? Now, for those of our listeners that, what is sublingual, you actually place it underneath your tongue. You've got the lingual artery system, a lot of blood flow that's underneath your tongue, and the drug actually gets passively diffused into the lingual system. So you actually, regardless if you've had a large dinner, you don't have an effect of the gastric emptying time. So you have a lot faster onset. Just like nitroglycerin tablets, if you're having any angina, about to have a heart attack, it's one of the faster ways of absorption. So the thought process here is we've had so many patients, and I also, from a pharmacist perspective, recently in my career, the last 6 years, I've been working in psychiatry. And we touched base on this. A lot of psych medications cause erectile dysfunction. That's just one of their adverse effects. So we've always used a sublingual base for many other APIs. I also work in detox. We use buprenorphine. When we're titrating, I have a lot of patients that just want to get off of it because now they've chronically been on buprenorphine for so long that we'll use very low doses of buprenorphine to titrate them off. So the sublingual dosage form, really, if you think about it, sex is a spontaneous activity. You want a fast onset. Usually it's at night, so you've had some dinner. So a tablet necessarily wouldn't work. So, or it will work, but there might be a 2 to 3 hour lag time or an hour lag time, depending on how heavy that meal is. So the sublingual route is a great route for it. Combining two PDE5 inhibitors, even at a lower dose, you get that short acting and also that long acting, right? So the sildenafil is going to be more of a shorter acting, and the cialis is longer acting. So that was kind of the thought process behind being able to come up with a dosage form in a sublingual.
So just to clarify, Ken, for our listeners, so you
Sure.
basically took the best of both on the market and you compounded it into what's now rugiet.
Correct. And recently we just added another dosage form, API, into the same dosage form, which is apomorphine, which is a D2 receptor agonist that works in the brain. And then it's also a peripheral vasodilator. And we've seen great efficacy also with that at low doses.
So you've added that into the rugiet formulation, or you have another pill?
Oh, no, we've added it. We've actually added it into that dosage form also. And again, this is after the physician's done their entire workup and if they feel that the patient, this would benefit the patient the best.
So from a patient perspective, when you take a pill like Viagra, how long does it take before it starts working?
Depending on gastric emptying time, 30 to 45 minutes get into,
okay.
Yeah, that's usually the average.
What about Cialis?
Same.
So it's 30 to 45 minutes for Viagra or Cialis. The difference being that Cialis may not give you as potent of an erection, but it will last longer. Whereas Viagra will give you a pretty potent erection, but the half-life is shorter. How long does it take for a rugiet pill to work?
So peak plasma concentration, just the rule of thumb, is usually at 11 to 12 minutes is when it's peaking. The sublingual usually takes about 6 to 8 minutes to dissolve underneath the tongue. We are working on some PK studies currently to be able to get definitive times, but the rule of thumb for any sublingual is usually about 11 minutes.
Yeah, that's pretty significant. So really, you're cutting down the time by a third, really, and it's really because of that sublingual route where you just take the pill, put it in your mouth, and let it dissolve, right?
Yep, sublingually underneath your tongue. Try to keep the melted there as long as possible, because what's really important is that passive diffusion of the drug underneath the epithelium, underneath the tongue, into the vasculature. Yeah. So, if you can just kind of chew it, I've had some patients just kind of chew it up, swirl it around, and swallow it. They'll get some gingival, they'll get some buccal, but you really, to get good sublingual, you really want to keep that melted molten there as long as possible, and then you get a better passive diffusion. And that's how we created the dosage form. When I really came up with the dosage form, that's one of the real important things. There's a lot of dosage forms out there, rapid dissolve tablets. They work really well. But the only problem with them is you're not really getting true sublingual dosage absorption. You're probably getting a little bit of gingival and some buccal, and you'll probably end up swallowing the rest of it. That's going to go through gastric absorption. But the only problem is a lot of these PDE5 inhibitors, they're very sensitive to the pH of the stomach. So if you ever look at the coating on a Viagra or Cialis, they're very heavily thick coated to prevent that pH of 2 in the stomach, to get through that, because you're actually getting a lower GI absorption. So that also has an effect too. So even if you use a RDT, you might get quite a bit of that degraded in the stomach.
Yeah, so really the sublingual route is really the most efficient way to get it into your
Correct.
system. What kind of dosing do you have? Like, how many different doses do you have for rugiet?
Yeah, so people can touch on this from the physicians. Currently, customer facing, we have, I think, 4 or 5 options, but then the physicians have an array, and he can touch base on that, on all the different strengths and options that they can provide.
Yeah, so Bobby, let me just comment on that. So really what we've done is, when you come to the website and we present the options to the patient, we have 4 formulations, all of which include sildenafil, tadalafil, and apomorphine. And then we have 4 different dosage strengths of those 3 ingredients. And so, kind of more of a low level, a medium, a higher, and the highest strength. And so the reason we've done it that way is we found that, when you really present so many different options to patients, it just becomes overwhelming because, people coming to our site for help don't always understand which medications they need to be on at what doses. So we wanted to really simplify it from the patient perspective. That being said, our doctors are extremely well trained and educated in the matter, and on their end, they have the ability to do a lot more. They can use even lower doses, even higher doses, different combinations. They could remove one ingredient, they could add another ingredient, and they can adjust the medications really to make more of a customized experience for the patient. And if a patient comes in saying that, tadalafil always causes them back pain and they just cannot deal with tadalafil, the physician can and does have the ability to offer a combination without the tadalafil. And so we really want to make sure we're listening to our patients and we are, customizing their treatments to the best of our physician's ability. But at the same time, we didn't want to make it so overwhelming for them when they come to the website.
So what's the process then? If a patient wants to get rugiet, what are the steps involved for them to be able to get the product?
Yeah, so it's actually quite simple. They would come to our website, click on the sign up button, and that would immediately direct them to our online medical questionnaire. And that involves capturing some demographic information, their photo and photo ID, which is a regulation that we have to comply by, and then their health history. And so there's a series of questions there to obtain that information that our doctors will need in order to safely prescribe our treatment options. And then they come to a product selection page where they have the ability to request a certain dose and an amount of dose that they want ordered and shipped to them. Obviously, there's a payment page there. And then once the order is complete, their consultation gets sent off digitally to one of our licensed and board certified physicians. And so our physician will then review all of their medical information, review the medications they've requested, and make a determination. And they'll determine whether they feel that requested dose and combination is suitable and optimal for the patient, or is there a need to change that based on their health history and perhaps their prior treatments and so forth. And so really what we wanted to design is a platform in which the patient and the physician both have a say in the patient's health care, and which is really what we strongly believe should be the case. And so we certainly don't want the patient to dictate their treatment, if that may lead to unsafe or ineffective treatment. And so ultimately our physicians make that determination, but they do, certainly respect the requests that the patients have put in. So really that's the ultimate process. If the physician feels that one of our treatment options, in their opinion, is safe and would likely benefit the patient, then they would approve the prescription. The medication gets filled at one of our partner licensed compounding pharmacies, and the medication then gets shipped to the patient's door. And all of this typically happens in, within 48 hours, depending on the day of the week, sometimes 72 hours, but fairly quickly.
Yeah, no, I think what I love about this model, and ultimately why I invested in Rugiet, is I just think it makes this whole process so much more discreet and convenient for patients. Instead of having to go to your primary care physician every time or go to see a urologist, they can literally do this through telehealth and virtually fill out their information and really get this shipped right to their house. And so there's a lot of really positive things about that whole process of this that I think is unique.
What are some of the more rewarding things that have come out of this, endeavor for both of you from a men's health perspective?
Yeah, so I guess I'll let Ken answer for himself, but my response to that would be a few things. One is just the learning. I mean, everything that I've learned since coming on board as Chief of Medicine of Rugiet has been nothing but eye-opening and a positive experience for me. And, I think through the learnings that I've obtained in just, launching our ED, treatments and questionnaires and dealing with our doctors, I just see so much opportunity there to help men and women in so many other aspects that just currently don't exist. And I think, Bobby, you kind of touched on it there when you were talking about reasons you really like Rugiet, but one of them is accessibility. And I think the fact that we are now becoming much more accessible to people who otherwise would not have maybe wanted to or had the ability to go see their in-person doctor to have some of these issues dealt with is something now that I feel more comfortable with. And in introducing, hopefully, down the road, other treatments for other disease states is something that I find very valuable. And then secondly, for me, it's really hearing the patient stories. I mean, when I can hear firsthand the patient feedback, when we reach out to patients, and we do so quite frequently, and our patients reach out to us and just tell us the changes that our doctors, our medications, our customer care, our customer care is unbelievable, and they'll reach out to them, and sometimes they'll just tell us just their experience they had with customer care, speaking with them and listening to them. And I think that feedback to me is really the most valuable and important part of my day-to-day, I feel. So Ken, I don't know about you, but I'll let you answer.
Yeah, so for me, it's huge. Professionally, personally, it's a game changer for me, because 20 years practicing as a compounding pharmacist, the rule of thumb is you'll find 1 out of every 100 doctors that's pro-compound. They'll love the idea, but they'll never write a compounding medication themselves. It's just not something that was really taught in medical school, or they just really haven't taken didactic courses outside of that. It's not within the realm. And a lot of the physicians are, worked in institutional settings. So, on a professional level and personal level, people will be like, yeah, you're talking about this compounding. Does it really work? Where are the clinical trials? Where are the studies? But as a pharmacist, in a community setting, and then also working in assisted living facilities, detox centers, I pretty much worked, I've never said no to a job, never. So I've worked, luckily, in my 20 years of experience, I've seen so many different settings and so many patients, whether it was in assisted living facilities for wound care, where we could heal a wound within 3 to 4 days with a custom compounded topical, versus there's nothing available for that patient, right? So when you've seen all those successes, but then you're always just hearing, where's the clinical trials? Where's the clinical trials? Does it really work? This, for me, is just huge personally, that when you see so many success stories, that finally patients are like, yeah, there's something here. Now, do we know exactly clinically? Do we have the PK studies? No. But we know that there's clinical significance and a lot of effectiveness in combining some of these therapies. And that's necessarily, it is our fault as pharmacists too. We've been terrible at collecting data. We've been terrible at collecting patient outcomes and successes and being able to bring that back to pharma. So I think from the compounding, I think what Vipul said is so true, is the accessibility, but then now allowing also patients to know that there are alternative treatments. Just because there wasn't a commercially available product that didn't work for you, we can try other alternative options in a different dosage form to get you there, right? But that might mean that there's lifestyle modifications along with that and all these other things, but there could be a dosage form with these APIs that'll work for you. And that works in so many different facets and so many different disease states and compounding. So for me, I'm super, super excited where we are with telemedicine, what it's done for compounding. I think the market is huge in the amount of success stories that we're going to have with patients, whether it's plantar fasciitis, with a simple topical, to erectile dysfunction, and especially with women's health. And we definitely know within this hormone replacement therapy, anti-aging, personalized medicine, all these different dosage forms are very customized to the patient. Whether this patient can't sleep, this one can, but they're getting hot flashes. So I think compounding is only going to grow through the accessibility with telemedicine, but it's also educating patients that there are other alternative dosage forms out there.
Yeah, Ken, thanks. I think you brought up a few good points. Compounding, I have an anesthesia and chronic pain background, so we're a little bit more familiar, but you're right, it's not something that is widely accepted in all fields of medicine, but it's a great way to sort of bridge the gap in the more personalized medicine space. And then I also liked how you talked about being able to use this as a tool in the entire toolkit of lifestyle or treatment of an underlying medical condition. So I think that's important. One last question here before we finish up. We've spoken a lot about men's health in the context of rugiet. What about women's sexual health? Is there anything that you guys have on the horizon, or anything that you want to say in the context of women's health as it relates to rugiet? I'll open up the floor.
Yeah, no, so what's fun about this is between myself and Vipul, and then also from the telemedicine, marketing, digital marketing side, is I could throw hundreds of different compounded medications, but from Vipul's side, obviously from the diagnosis perspective through telemedicine, he has to go through that whole conundrum of how can we be able to diagnose this, or what is the safety efficacy profiles behind it. And then there's the other factor is there actually a tangible market through telemedicine and the marketing, whether it's Facebook, Instagram, and SEO. So from my side, from a compounding side, we always have something up our sleeves that we've seen work with patients on the ground through our clinicians on the ground. But when we start talking the telemedicine and the marketing through Facebook, Instagram, there's a real key collaboration between obviously the chief of medicine along with his team of practitioners, and then also the marketing team. That is it tangible and can that actually work in the real world?
Yeah, I think Deepti, Ken kind of gave you the more detailed explanation. The short answer is yes, we have had conversations about female health and certainly female sexual health products that we feel we could bring to market. However, I'm not going to give you any more detail than that because we have not gotten into the specifics of those conversations, and we're still quite early in that stage. But we have certainly had those conversations, and it's certainly something we'd like to do in the future.
One last question I have, just to keep this as comprehensive as possible, because we talked about, exercise, natural alternatives to erectile dysfunction. We talked about the pharmaceutical interventions like viagra, cialis, rugiet. I have a lot of patients also asking me about other treatments as well, specifically gainswave. Can you talk a little bit about that and how that works and what you feel about that?
Yeah, so for those of your listeners who might not know what gainswave is essentially low frequency shock wave. So it's an acoustic wave which meaning it's a sound wave essentially created by a device at a low frequency, and that type of treatment and therapy has been, as physicians, we've been using it for years in different areas of medicine. One kind of more common area that's used is with in urology. We see them using it, in lithotripsy and things to break up kidney stones. So the technology of sound waves has been there for a long period of time. What we're discovering now is that these sound waves used focused in certain areas of the body are showing to stimulate and regenerate tissue, and in particular vascular tissue, by stimulating by a complex pathway that involves growth, growth factors and release of growth factors and so forth at the cellular level. However, we're still not quite there yet with ED. There's more and more data coming in every day, and I certainly see that there's more and more medical spas, and even I've seen some at-home use devices that are designed to for this purpose, and essentially it's focused acoustic shockwave delivery to the penis and the tissues surrounding the penis, in the thought that it's going to increase the vasculature, and I'll say that I'll be the first to hope that we continue down that pathway, and if we can get away from temporary band-aids to a more definitive treatment for this disease process, I think we would all be extremely happy with that solution. But we just don't know enough about it yet. There's, from what I've read, there's some evidence that you might need continued treatment. Accessibility issues are still going to be there. The cost of treatment at this time. So there's still a lot of unknowns, but I certainly would hope that pans out in the future, and that would be, a great way of managing it if we can come to a solution that way.
Yeah, I've heard some good results, but to your point, accessibility has been an issue. There's not a lot of gainswave treatment places, but the treatment certainly sounds promising. Thank you, Vipul. Thank you, Ken, for providing such a comprehensive discussion on men's sexual health and sexual dysfunction. I've learned a lot from this. We always like to end our podcast, with a question. Deepthi, if you want to go ahead and ask.
Yeah, so one of the questions that we like to ask, and this is just, we like to promote overall lifestyle here, but both of you are really busy individuals. Vipul, you're practicing medicine and chief medical officer for Rugiet. Ken, it sounds like you have a lot of different projects going on aside from Rugiet. So what are both of your guilty pleasures?
Guilty pleasures? Oh, I don't know. I don't know so much if it's so much of a guilty pleasure, but I'll tell you where I waste a lot of time. It's typically with sports. I'm a big sports fanatic, so hockey and football are big for me. I think the fact that college football just ended yesterday is going to really open up my schedule now. And so sports and traveling. Me and my wife love to travel. We find every excuse that we have to travel. Most recently, we were in Finland, and we got to see the Northern Lights. We actually just recently got married, and we delayed our honeymoon, so our next trip's going to be our honeymoon in a couple months. So,
oh, wonderful.
Yeah, so traveling is my other guilty pleasure, if you want to call it that.
Guilty is the wrong word, but we like to use it in the context of what do you like to do when you're not working. Yeah.
Yeah. Those would be mine. Ken?
Yeah, for myself, I love road course racing, so I have my race car driver license. So I do at least 5-6 races a year, try to get back out in the track. I used to instruct for Porsche, so I really love teaching and driving. And then I live in sunny Miami, so I love the beach. I love the hot weather, so it's great. Life's great.
Awesome.
Very neat. Yeah, it always helps us round out our guests because we find out something interesting also about you guys.
Can you share with us where a patient or someone with erectile dysfunction could go to find out about Rugiet?
Sure, yeah. So our the URL for our website is www.rugiet.com. That's rugiet.com. The other sometimes it's hard for people to remember, so we also have another website that directs you to that Rugiet website, and that's www.roartonight.com, ROAR tonight.com. So either one of those URLs will take you to our website, and feel free to poke around in there. There's a lot of interesting information on the science, on the providers, on our treatment options and where we came from. And yeah, we'd be happy to have anyone reach out to us with any further questions. There's a customer care email on there. And I think the one last message I'd like to send to all your listeners is, regardless of if you come to Rugiet or you go to any other website or you don't go to a website and you just go see your doctor, I strongly encourage all of your listeners to take their health into their own hands and be your own health advocate, and forget about the shame and the stigma that comes along with sexual health issues and any health issue for that reason, and always just look out for yourself and your health. So that's my leading words there.
Awesome. Thank you so much, Vipul and Ken. Thank you for the time and the education. And
thank you, guys.
Yep. Deepthi,
thank you. Appreciate it
for the episode. And we hope to have you back one day.
Absolutely.
Thank you.
Thank you. It's been a pleasure.